Hey everyone, and welcome to this Clinical Explainer. If you're a nursing student or a clinician, you're going to want to pay close attention to this one. Today, we're diving into a real-world, seriously high-stakes scenario right on the ward. We've got a post-op patient who is rapidly deteriorating right before our eyes. We're going to unpack the clinical data together to clearly explain the incredibly dangerous link between undisclosed alcohol use and delirium tremens, relying strictly on the patient simulation file we have right in front of us. Let's get into it. So, meet our patient, Douglas Henderson. He's 54 years old and was admitted to the ortho ward for what seemed like a pretty straightforward situation: a right ankle open reduction and internal fixation, or ORIF, surgery after a fall at home. But as you'll see in just a minute, the surgery itself is literally just the tip of the iceberg. Douglas has an undisclosed history that is about to trigger an absolute clinical emergency. All right, here's our game plan for today. We'll look at the patient background and surgery, track the post-op deterioration, check the vital signs and assessment, dive into pathology and critical risks, and wrap up with the isobar handover. Okay, let's kick things off with Section 1, Patient Background and Surgery. So, on paper, Douglas is on day 2 post-op, recovering from that right ankle repair. But take a really close look at his past medical history. We've got gastritis, peripheral neuropathy, and hypertension. Now, during admission, his history of alcohol use was kind of minimized. He disclosed his drinking strictly as social. But guys, those 3 comorbidities, the stomach inflammation, the nerve damage, and the high blood pressure, those are absolutely glaring clues pointing to chronic alcohol use. And it's something we can never, ever ignore when evaluating a patient's true risk profile. Moving right along to Section 2, the post-op deterioration. It is actually wild how fast things spiral out of control on day 2 as he transitions from routine recovery into a severe withdrawal state. Watch this rapid escalation over less than 12 hours. At 8 a.m., the signs are kind of subtle, right? He's a bit tremulous, he refuses his breakfast, and he complains of extreme auditory and light sensitivity. Fast forward to 2 p.m. The intensity is really building now. He's diaphoretic, pacing his bed space, which, remember, he's a non-weight-bearing ankle, with a fine tremor and a spiked blood pressure of 155/95. Then, by 7:30 p.m., it culminates into full-blown delirium. He's severely agitated, trying to climb out of bed, completely drenched in sweat, and actively shouting at visual hallucinations, literally shouting at spiders. I want you to really look at this contrast between the early morning and late evening. On the left, we've got simple tremors, that heightened sensory response to light and sound, and no appetite. If you aren't super vigilant, it'd be so easy to brush this off as just post-op grogginess or pain, right? But compare that to the right side. By late evening, we are looking at severe late-stage delirium signs. He's extremely agitated, sweating through his gown, having terrifying visual hallucinations, and creating a massive, massive fall risk. And bam, this is the exact moment the clinical alarm sounds. The system flags a critical alert: severe alcohol withdrawal syndrome, or AWS, with a staggering score of 18, compounded by those active hallucinations. This isn't just a rough recovery anymore. This is a full-blown medical crisis demanding immediate intervention. Which brings us to Section 3, Vital Signs and Assessment. Okay, the physical symptoms are one thing, but let's look at the hard data driving our clinical picture to see just how much strain his body is under. The severe sympathetic overactivity here is just glaring. Douglas's nervous system is in complete overdrive. He's highly tachycardic with a heart rate of 128 beats per minute. His blood pressure has surged to a hypertensive 185/105. He's febrile at 37.9 degrees Celsius. Put it all together, and these numbers mathematically confirm a state of severe withdrawal, perfectly lining up with that AWS score of 18. Let's dig a little deeper in Section 4, Pathology and Critical Risks. To truly understand the underlying danger Douglas is in, we have to pivot to his pathology results. See this number? 0.6. That is his magnesium level, 0.6 millimoles per liter, which is critically low. This is super common with poor nutrition and renal wasting in chronic alcohol abuse. And when you pair this profound electrolyte deficiency with his GGT level, which is elevated at 180 units per liter, you have definitive, hard laboratory evidence pointing to chronic, severe alcohol use and a highly compromised system. So what does this all mean for Douglas? Well, thanks to that massive magnesium drop and his sympathetic nervous system firing on all cylinders, he's staring down some incredibly serious, life-threatening risks. He is at immediate risk for impending delirium tremens and severe withdrawal seizures. On top of that, his sustained high heart rate and blood pressure put him at a very real risk for total cardiovascular collapse. And practically speaking, with all this agitation and delirium, his fall risk is off the charts, which is catastrophic considering he just had surgery on that ankle. All right, how do we handle this? Section 5, the ISO bar handover. When faced with this kind of mounting data, we rely on the ISO bar framework to make sure nothing gets missed in the chaos. First, identify. Douglas Henderson, 54, situation, severe alcohol withdrawal syndrome with impending delirium tremens. For observations, we rapidly rattle off the critical data. Heart rate 128, BP 185 over 105, AWS score of 18, and active visual hallucinations. Background, day 2 post-op from an ankle ORIF with undisclosed chronic alcohol use disorder. And our assessment, severe sympathetic overactivity, presenting an imminent risk of seizure and cardiovascular collapse. And finally, the R, our recommendations and immediate actions. You gotta be decisive here. First, trigger that medical emergency team or MET call immediately. You need to administer stat IV diazepam. Depending on your specific hospital protocol, you'll typically start at 5 to 10 milligrams to manage that severe agitation and lower the seizure threshold. This absolutely must be given alongside 300 milligrams of intravenous thiamine to prevent Wernicke's encephalopathy. And for immediate patient safety, initiate one-to-one nursing care and get Douglas into a low-stimulus room right away to reduce the environmental triggers that are making his hallucinations and sensory sensitivity worse. It's kind of crazy how fast a routine recovery can turn into a literal battle for a patient's life, isn't it? So reflect on Douglas's story and ask yourself, if a casually reported history of quote-unquote social drinking can mask the seeds of impending delirium tremens, what vital hidden clues might you be missing during your very next patient assessment? Keep your eyes open, trust the clinical data, and never ever ignore those early warning signs. Thank you so much for joining me for this explainer, and I'll catch you in the next one.